Committee of Kerala Society of Ophthalmic Surgeons. Today we are having the 8th module of PG classroom, which we are doing once in every 2 weeks. So in this meeting, in this PG classroom, a postgraduate resident will present a case, and an examiner, an external examiner will discuss the case and will take the discussion forward. So today, Dr. Ramalakshmi, she's a professor of ophthalmology from Tanjavur Medical College with us as examiner, and Dr. Hari Ramakrishnan from CSI Medical College, Karakoram as the mentor, and Dr. Lakshmi Pradeep as the student. So now I invite Dr. Lakshmi to start the discussion.
Good evening, madam. Presenting the case of 71-year-old male patient came to our OPD with the complaints of defective vision in the right eye for past 2 years. History of presenting illness. This 71-year-old male patient came to our OPD with gradual, progressive, painless diminution of vision in the right eye for past 2 years. And patient had an history of episode of redness and severe pain, defective vision in the both eye 2 years ago, and which was associated with vomiting and headache. For that, laser treatment was taken in both eye elsewhere, details of which are not available. For that, after that, there was no similar episode and he was not using any topical medications. Then 1 year back, he presented to our OPD with defective vision and underwent left eye cataract surgery, and he was started on topical anti-glaucoma medications. Brimzolamide and brimonidine eye drop combination, 1 drop BD right eye, ripazudil eye drop, 1 drop TID right eye, brimonidine eye drop, 1 drop TID left eye. There is no history of flashes or floaters, no history of headache, no history of nausea, vomiting. There is no history of color halos. Then past ocular history.
Okay, wait. Before going to the past ocular history, the history of present illness, you have told that a gradual, progressive, painless diminution of vision in the right eye for the past 2 years. But in the history of present illness, you should elaborate the defective vision for distant vision or near vision or any diurnal variation is there. Okay?
Okay.
Why it is important?
And distant vision is usually affected in both the distant and near vision is affected in cataract patient,
cataract and old age patient also.
Old age patient.
Yes, because the patient may, because you have told that it's a painless progressive loss of vision. So the patient, you should rule out the other conditions from the history also. Okay. So you told that it's due to maybe due to cataract. And also the same for the diurnal variation also. Okay. And also you have told that the redness and severe pain, defective vision both is 2 years ago.
Yes.
So it was the vomiting, headache, and the laser treatment. Everything should come in the past ocular history. Okay.
Okay, madam.
You should not say in this. And then some more history is also necessary. History of wearing glasses. Okay. Because the positive history is followed by the all negative history, because maybe the glaucoma case may be in the long case. Okay. So no any history of wearing glasses, any history of frequent changes of glasses, history of any drug intake or maybe a topical steroids, anything. So this may be any ocular injuries. It may be ruled out in the history of present illness also. Okay. Okay, you go to the ocular history. Past ocular history.
Past ocular history, history of cataract surgery in the left eye 1 year ago, and he was started on ocular medication for intraocular pressure. Then history of laser treatment taken 2 years ago, using spectacles for past 8 months, and there is no history of.
Yes, why are you talking about the spectacles for past 8 months? Is there anything important, significance?
if there is increased IOP, there will be frequent change in the spectacles due to
Yes.
ciliary body ischemia.
Still more anything significant? Using spectacles.
Then cataract also.
Yes, cataract also.
Cataract also is causes diminution of vision, frequent
Vision.
changes.
Yes, and myopes. Myopes may have the more prone for the glaucoma case associate. Okay, next.
No history of intravitreal injection, no history of ocular trauma.
Why this is important? No history of intravitreal injection.
No history of intravitreal. If there is any intravitreal injection, it is patient is more prone for cataract.
Yes.
And in history of ocular trauma also, there is the patient may develop cataract, or there is any angle structure. There will be any injury to trabecular meshing.
Still more in intravitreal injection. What is the importance?
Patient is a diabetic.
Yes.
Diabetic patient.
Yeah.
And if there is neovascular chance of PDR and progress to neovascular glaucoma.
Yes.
For that, IOP rise may be seen in will be there in neovascular glaucoma.
No, that is okay. But in intravitreal injections, sometimes maybe the diabetic macular edema, we are giving the steroids, intravitreal steroids. Is it? Triumphs, like that. So that may cause increase the intraocular pressure. Okay. Then
no history of ocular trauma.
Okay. Then past systemic history.
Past systemic history. He is a known case of systemic hypertension for 10 years, type 2 diabetes mellitus for past 6 years, dyslipidemia for 10 years, and coronary artery disease for 10 years, and status post angioplasty 4 years ago.
Okay. What is the importance of systemic hypertension here?
Systemic hypertension itself is an risk factor for primary open angle glaucoma.
Yes.
And ocular hypertension.
Okay. Why? How it is important? Hypertension.
Systemic hypertension. If the patient is using antihypertensive, patient may go for nocturnal hypotension, and which will progress the glaucoma changes. Yes,
hypotension, hypoperfusion, and also the diastolic perfusion pressure. So if it is less than 55, it is a risk factor for the glaucoma. Okay.
Type 2 diabetes mellitus, dyslipidemia, coronary artery disease. Then he is on regular medication, tab metformin 500 mg BD, tab amlodipine 5 mg BD, tab atorvastatin 10 mg OD, and tab ecosprin 75 mg OD. And there is no history of CKD, CVA, and bronchial asthma. Personal history, mixed diet, sleep and appetite normal, bowel and bladder habits regular, no addictions, no history of any drug allergy.
What addictions you expect?
Smoking.
Yes, good. Then
alcohol use.
Alcohol, it's not such significant. Any drinks? Any drinks? It's a clue. I'm giving clue. Coffee or tea?
Coffee.
Caffeine. Caffeine. So large intake addiction may cause, but it's not significant.
Okay.
But it may increase.
Okay.
But tea has less incidence because it has flavonoids which will increase the blood flow to the optic nerve.
Okay.
Okay. Then next.
No history of any drug allergy. Family history, no relevant family history. Then general physical examination.
What is the importance of family history?
Family history in a primary glaucomas, family history is important, like primary open angle glaucoma, there will be gene affecting optineurin and myosin gene affecting, and there will be in primary angle closure glaucoma also there is increased incidence in the siblings and siblings and
offspring.
Yes.
Okay. Okay, proceed.
General physical examination, patient is moderately built and nourished, well oriented to time, place, and person. No pallor, cyanosis, clubbing, lymphadenopathy, or edema. Systemic examination, pulse 80 beats per minute, BP 140/90 mmHg in upper limb at sitting position, cardiovascular system S1, S2 head, no murmur, respiratory system normal vesicular breath sound head, gastrointestinal system per abdomen soft and non-tender, no organomegaly, central nervous system within normal limits. Then vision, ocular examination vision, right eye 636 with pinhole 618, subjective refraction -1 spherical with -2.5 cylindrical into 90-degree axis improved to 618, and near vision with +3 spherical diopter and 6, and vision left eye unaided vision 618 with pinhole 66 parts, subjective refraction -1.25 cylindrical into 90-degree axis improved to 66 parts, and near vision +3 spherical and 6.
In the ocular examination, first you should start with the head posture, facial symmetry, yes, eyes are orthophoric, like that. You start with ocular examination, like that. So you tell me what about the head posture, facial symmetry, like that?
Normal head posture, no facial asymmetry, patient ductions and versions are full in all
extraocular movements.
Extraocular movements, ductions and versions were full in all direction.
Eyes are orthophoric.
Eyes are orthophoric.
How will you say that it is orthophoric?
Hirschberg test, the pupillary reflex.
Okay, continue.
Then examination of right eye, lids and adenes are normal in position, margins normal, skin over the lid normal, eyelashes normal, palpebral aperture normal width and height, lacrimal apparatus normal, rhoplastous negative, conjunctiva normal, cornea normal shape and transparency, corneal sensation intact. Then anterior chamber, Van Heren's grade 3, no cells or flares, iris normal color pattern, no new vessels, peripheral iridotomy present at 8 o'clock position and which is patent. Pupil single round 3 mm size, reacting to light, grade 1 RAPD. And lens, nuclear sclerosis grade 4 plus cortical cataract, anterior vitreous, hazy view. Then examination of left eye, lids normal in position, margins normal, skin over the lid normal, eyelashes normal, palpebral aperture normal in width and height, lacrimal apparatus normal, rhoplastous negative, conjunctiva normal, cornea normal shape and transparency, corneal sensation intact, AC normal depth, no cells or flare, iris normal color pattern, no new vessels, peripheral iridotomy present at 2 o'clock position and which is patent. Pupil single round 3 mm reacting to light, lens PCIOL, and anterior vitreous normal.
Oh, before, how do you say these findings? How do you say these findings? By examining which what?
Which finding, madam? Anterior
chamber. Anterior segment.
Anterior chamber, according to Van Heren's grading,
no. So first of all, you whenever you tell about the clinical features in right eye and left eye, you can say that's anterior segment examination with the torchlight and confirmed with the slit lamp examination.
Okay. With
Okay.
torchlight.
First of all, you're testing with the torchlight only.
Torchlight.
Then it is confirmed by slit lamp examination.
Slit lamp examination.
Yes.
Torchlight.
Oblique examination. Then confirmed by, because the one hair it is confirmed by slit lamp only.
Slit lamp.
And cells and flare only slit lamp only you can confirm. Okay, sir. So what is VH3 you told me?
Van Heren's grading, according to Van Heren's grading, grade 4 is anterior chamber depth is more than the central, more than the corneal, peripheral corneal thickness, and grade 3 is between the 1/4 to half of the corneal thickness, and grade 2 1/4 of corneal thickness, and grade 1 is less than 1/3 of corneal thickness.
Okay. How do you say that the PI is patent?
PI is patent in retroillumination. Put the slit lamp viewing system and light in coaxially, and put the retroillumination. From retroillumination, we can see a transillumination defect in the area of peripheral iridotomy.
Pupils, you told that it is the grade 1 RAPD.
Yes, ma'am.
What is grade 1 RAPD? So what are the grades of RAPD?
Grades of RAPD. Grade 1 RAPD, there is the initial small constriction followed by dilatation. Grade 2 RAPD, there is a small initial pupillary stall followed by dilatation. Grade 3, there is rapid dilatation. Grade 4, dilatation after prolonged illumination like 6 seconds. And grade 5, there is rapid dilatation without any constriction.
Okay. Then continue.
Then IOP IOP right eye 60 millimeters of mercury with Goldman applanation tonometry at 10:30 a.m. Patient is on brinzolamide and brimonidine eye drop combination for 1 drop BD and ripazodil eye drop 1 drop TID. Left eye IOP 8 mmHg with Goldman applanation tonometer at 10:30 a.m. On patient is on brimonidine eye drop TID.
Okay, continue.
Then gonioscopic, right eye gonioscopic examination with the Goldman 2 mirror lens. According to RP center system, and there is a superiorly there is grade 6 with peripheral anterior synechia, inferior quadrant grade 5, and inferior nasal and temporal quadrant grade 5. Inferior quadrant also there is peripheral anterior synechia present. Then left eye gonioscopy with Goldman 2 mirror lens. According to RP center grading, grade 6 in all 4 quadrant.
Okay, what is the direct gonioscopy? It is indirect gonioscopy. What gonioscopy you did here?
We are using indirect gonioscopy.
Yes,
Direct gonioscopy is a convex button-like lens, which is commonly used 50 diopter convex lens, which is commonly used in intraoperatively to view the erect view of angle structure.
Name some direct gonio lens.
Direct gonio lens, Schaffer's test, Schaffer's gonio lens, and Barker's gonio lens, Copy's gonio lens, then Sean Jacob lens.
Okay, can you differentiate the difference between the direct gonioscopy and indirect gonioscopy? Any more points? Yeah.
In direct gonioscopy, we will not manipulate the angle. there is no manipulation on the angle. It is magnification is less compared to indirect gonioscopy, and which is simultaneously we can examine the other eye also, and it is usually commonly used in intraoperative procedures.
Which is
And
comfortable? Which is comfortable one?
It's comfortable.
Which one? Direct or indirect?
Direct is comfortable.
Direct. Okay, go to dilated
Indirect.
retinoscopy.
Indirect.
No. Go to retinoscope. Retinoscope.
Then and dilated retinoscope if done with tropicamide eye drop 2/3 meter distance. Acceptance is -1 spherical with -2.5 cylindrical into 90-degree axis, which is improving to 6/18 vision. And acceptance in the left eye -1.25 cylindrical 90-degree axis, improving to 6 parts. Then dilated fundus examination, right eye using 78 diopter lens, pupil 7 millimeter diameter, distant direct ophthalmoscopy, dull glow with peripheral spokes like opacities, media hazy due to lens opacity, disc color, size, shape, margin, vertically oval, normal sized disc measuring 1.8 millimeter vertically, and cup is measuring 1.4 millimeter vertically, distinct disc margin, inferior rim thickness is less than superior rim thickness, NRR thinning noted inferiorly, and peripapillary atrophy and nasalization of vessels present. There is no disc hemorrhage or collaterals. Cup disc ratio.
What is okay, tell me.
Cup disc ratio 0.9:1, bionetting present, bearing of vessels present, laminar dot sign present.
What is bionetting sign?
Bionetting sign is where there is neuroretinal rim thinning. There will be dipping of the vessels inside under the neuroretinal rim, and there is a double angulation of vessels can be seen.
Okay. Okay, continue.
Then A by B 1/3 macula, FR not seen, background dot and blot hemorrhages present, RNFL hazy. Then dilated fundus examination of left eye, pupil 7 millimeter diameter, distant direct ophthalmoscopy, good red glow, disc color, size, shape, margin, vertically oval, normal sized disc is 1.8 millimeter diameter, cup 1.2 millimeter, distinct disc margin, inferior rim thickness is equal to superior rim thickness, peripapillary atrophy present, nasalization of vessels present. There is no disc hemorrhages or collateral. Cup disc ratio 0.7:1, bionetting present, bearing of vessels present, laminar dot sign present, arteriovenous ratio is 1/3, macula normal, FR dull, background dot and blot hemorrhages present, cotton wool spots present in the superior temporal arcade. Examination with red-free filter, there is diffuse RNFL defect.
So told about the collaterals. Collaterals. What is important here? Why do you tell about this collaterals?
Collaterals are seen in case of ischemias, disc ischemias.
Then
retina also in retinal ischemias, collateral vessels can be seen.
Occlusion, vascular occlusion.
Vascular occlusion.
There will be collaterals. Then so you told about the diffuse RNFL defect, RNFL defect. What was the grading of this defect?
Madam, I didn't get it.
What are the types and grades of this RNFL defect?
Okay, madam. There is a slipped RNFL defect, there is wedge-shaped RNFL defect, and there is diffused RNFL defect.
Continue.
Okay, madam. Summary: 71-year-old male patient who is a known case of systemic hypertension, type 2 diabetes mellitus, dyslipidemia, coronary artery disease, presented with complaints of gradual, progressive, painless diminution of vision in the right eye, 2 years.
Okay. Wait. You have investigated all this in this case.
Yes, madam.
Anything left? The glaucoma case you are going to present, is it?
Yes, madam.
Which investigation is listed here?
Investigation field.
Yeah. What about field?
Field, madam, there is a gross RNF depression, field depression is present in both eyes.
That is fundus examination, you have told, no? So
Yes.
Field examination, visual field testing is there, no?
Confrontation test, madam.
Yes, that is for the UGs, confrontation. For your PGs, what test you should do?
Ham-free visual field.
Yes, only the screen is there. Or now automated perimeter is there. So without field testing, glaucoma case is not over.
Okay, madam.
So what's the triad of this glaucomas? IOP,
increased
examination,
elevated
field defect.
Yes, madam.
So you are not completing the field defect, you go to the summary.
Okay, madam. In both eye, there is diffused depression and field constriction present in 10-dashed.
Yes, because the cupping is the 0.9, no? 0.9
yes.
in the right eye, in the 0.7, definitely there will be field defect.
Yes, madam.
Yes, proceed. Summary.
Okay, madam. A 71-year-old male patient who is a known case of systemic hypertension, diabetes mellitus, dyslipidemia, coronary artery disease, presented with complaints of gradual, progressive, painless diminution of vision in the right eye, 2 years duration. Status post both eye, peripheral laser peripheral iridotomy. Status post left eye cataract surgery, and he is on topical anti-glaucoma medications for 1 year. On examination, best corrected visual acuity, right eye 618. Near vision N6 and left eye 6 parts near vision left N6 and on anterior segment examination patent PA.
Wait. Before the anterior segment examination, whenever you summarize this case, a 71-year male you told, no? So
yes.
With the past history of acute attack of primary angle closure in both eyes 2 years back.
Okay, madam.
You should tell this past history.
Okay.
That is important for your case. Because
okay.
You should tell because that is a positive history for your case.
Yes.
Yes.
Anterior segment examination, patent peripheral iridotomy in both eye present, right eye grade 1 RIPD, right eye nuclear sclerosis grade 4 with cortical cataract, and left eye pseudophakia. Then gonioscopic examination, right eye open angle in nasal and temporal quadrant, and peripheral anterior synechiae is present in superior and inferior quadrant. Left eye open angles in all 4 quadrants. Then dilated fundus examination, right eye short 0.9 cupping with inferior rim thickness is less than superior rim, and left eye 0.7 cupping, inferior rim is equal to superior rim thickness, and both eye with characteristic bionetting, bearing of vessels and laminar dot sign, and diffuse RNFL defect is noted in left eye with red free filter. Dot and blot hemorrhages in the background of both eye with cotton wool spot in the left eye.
Yes.
I would like diagnosis. I would like to
Yes.
give
Okay.
differential.
Before going to the diagnosis, you have to now you know the what is the format of presentation of a glaucoma case? Is it?
Yes, yes,
Do you
madam.
understand? So this is the format, but this is a 1 hour session. This session is 1 hour. We cannot discuss all about all aspects of glaucoma. Okay.
Okay,
So
madam.
if the time permits, we can discuss more. Otherwise,
Okay.
we can discuss within this time limit. Okay.
Okay, madam.
Diagnosis. It is somewhat some interesting case. Okay. Okay. Diagnosis.
I would like to give differential diagnosis of one is primary angle closure glaucoma, and next is combined mechanism glaucoma. And left eye pseudophakia, both eye moderate NPD, non-proliferative diabetic retinopathy, both eye grade 3 hypertensive retinopathy, systemic hypertension, type 2 diabetes mellitus, dyslipidemia, and coronary artery disease.
So many systemic complications are here in this case. Associated. Why do you say that it's the primary angle closure glaucoma?
So because patient is giving typical history of acute attack of angle closure, and the patient symptoms subside with laser peripheral iridotomy, and in gonioscopic examination, there is a peripheral anterior synechiae is present.
So it may be a chronic primary angle closure glaucoma.
Yes, sir. Yes.
Maybe a chronic primary angle closure glaucoma. Okay. But here, and mostly the primary angle closure glaucoma, both eyes may be involved. Both eyes, the angles will be closed. But
Yes.
they may asymmetrical. But in this case, the left eye, it is open angles. In all quadrants, it is open angle. So
Yes,
what is the explanation you are going to give for this? But you told that's the primary angle closure glaucoma in both eyes.
In left eye, that may be an oppositional angle closure. After PI, the angle get open after PI.
Open. Oh, maybe. Okay.
Maybe.
Then anything?
So open, and it is IOP is after peripheral iridotomy.
Okay, IOP is reduced. Reduced. Then anything?
There is no peripheral anterior synechiae is
in the left eye. And also the lens, the history of past history, you have told that the lens extraction was done. In the left eye.
Oh, yes.
Okay. That may be the cause for reduction of the intraocular pressure.
Yes,
in this case. And also the acute attack. If it was, even though it was untreated, the 2 years back it was untreated, you told that. So the sequelae are sometimes there will be spontaneous angle reopening may occur. It may occur rarely. And also the treatment also laser PA was given. Patient. So that may be the explanation for open angles in the left eye. Okay. But whenever you tell the diagnosis, primary angle closure glaucoma or a chronic primary angle closure glaucoma with the advanced glaucomatous changes.
Okay, madam.
Because in the right eye 0.9 cupping, here in the left eye is 0.7. So the diagnosis we add with advanced glaucomatous changes and with advanced visual field defects.
Okay, madam.
What is the visual field defect in the right eye, in the left eye?
There is both eye. There is a gross visual field constriction. Is there?
Central field.
tunnel vision, but
Like,
left
yes.
eye it's
And
not correct.
the arcuate scotoma is also incomplete.
Mm.
Mm. So the field defect is also gross.
Yes.
So you should mention in the diagnosis.
Okay, madam.
Okay. Then we have to add right eye nuclear sclerosis grade 4
Yes,
with
madam.
the cortical
Cortical
cataract
cataract.
in right eye. You should add that in diagnosis. And also you told that both eyes, there's a combined retinopathy is there. Is it? It's a non-proliferative diabetic retinopathy, moderate non-proliferative NPDR, and grade 3 hypertensive retinopathy.
Yes.
So you told grade 3 hypertension. What are the features in the grade 3 hypertensive retinopathy in your case?
Grade 3 hypertensive retinopathy, there is dot and blot hemorrhages and cotton wool spots are there in left eye.
Okay, then
arteriovenous ratio is reduced.
yes. What is the normal AV ratio?
2/3.
2:3. Okay. Here it is 1:3. Yeah.
Yes, madam.
Any other changes you can expect? Because you told that's a grade 3.
Hard exudates.
No. AV cross AV nicking.
Second grade, there is
Yeah, you're telling it's the third.
yes, madam.
In addition, with the second, the third will be present with the
Yes.
averages and like that. Okay. Okay. What is the plan of management here?
Plan of management, madam.
In this patient.
In this patient, there is right eye. There is, in spite of using 3 group of anti-glaucoma medication, IOP is not at the level of target IOP.
So it's under control. Under control here. Is it?
Yes. But there is advanced cupping in the right
Coupling
eye.
is there. Yes.
Advanced cupping is in the right eye. So for this advanced cupping, IOP should be approximately less than 12 millimeters of mercury. Here it is 60 millimeters of mercury, not attain target IOP. And there is also diminution of vision, cataract lens thickness also increased.
Yes.
So I would like to go for combined glaucoma surgery.
Yes.
Combined.
Yes. Here also nuclear sclerosis grade 3. So it may reduce the intraocular pressure. So the aim is to maintain the target pressure and also to prevent the further deterioration of vision. So otherwise it may go for the next stage of glaucoma. What is that?
Madam, questions one more.
So it is to prevent the further deterioration of vision. Is it? The aim. So otherwise it will go for the next stage of glaucoma, which is the primary angle closure glaucoma. What is the next stage?
Primary angle closure glaucoma. Absolute glaucoma.
Absolute glaucoma. Yes, absolutely correct. Okay. With you can do the cataract surgery, then combined surgery with with the mitomycin C and like that. What surgery you will do for combined surgery?
Combined surgery, cataract surgery with trabeculectomy.
Trabeculectomy. Okay.
Okay.
Then
the peripheral surgical peripheral iridectomy.
Yes, you can do. Then any other newer surgeries? What is GAT? GATT.
Madam,
What is GAT? GATT.
glaucoma. I don't know, madam. I don't
know. Goniotomy assisted transluminal trabeculectomy. Okay. So this is the presentation. So in this case, we can do this only. because advanced cupping is there. Okay. Any other questions from Dr. Hari and Madam? Dr. Hari?
Yes, ma'am, I'm here.
Yes, you can also take questions.
You have discussed most of it, madam.
Within 1 hour, we cannot
Yes.
depict the treatment, investigation, so many things are there.
Yes, ma'am. Yes, ma'am.
This is a basic thing, that's all.
Yes, yes, ma'am. Yes.
If you want to discuss, you can ask, you can discuss.
Yes, ma'am. I think most of the things are already done. Lakshmi, can you tell us more about peripheral iridotomy, how it is done?
Peripheral iridotomy, there are 2 types, laser peripheral iridotomy and argon laser iridotomy. Usually, laser peripheral iridotomy is done with Nd:YAG laser iridotomy with 1064 nanometer wavelength, and in which the lasers are given to the usually 1 o'clock, preferred site is 11 o'clock to 1 o'clock position, and there is 150 micrometer to 250 micrometer iris defect is made, hole is created, and which help for equalizing the pressure between the posterior chamber and anterior chamber.
Yes, yes. So you generally choose the peripheral iris so that the iris is thin in the periphery, and try to locate it at the site of a crypt where the iris is thinnest. And it can be,
is also
pre-iridotomy is better to drop off
stretching of the
and give pilocarpine.
Pilocarpine.
Yes. And are there any drugs that can precipitate angle closure?
The drugs which can precipitate angle closure is the drugs causes topiramate and acetazolamide. These are the drugs which will cause the choroidal effusion and causes angle closure. Then mydriatic drugs like tropicamide, phenothiazine, Parkinsonism drugs, antihistamines, all these can precipitate angle closure glaucoma.
Yes. So it's either because of you induce a mydriatic such patients, by if you put a mydriatic in a susceptible eye, then there is a risk of developing angle closure. So those with anticholinergic effect, like you mentioned, antihistaminics, that can precipitate angle closure by pupillary block. And bilateral angle closure by non-pupillary block mechanism occurs with the drugs that you mentioned. Recently, topiramate, after they have started prescribing it, neurologists are prescribing it, we are seeing a lot of bilateral angle closure glaucomas, but that is not the pupillary block mechanism.
Yes.
So how do you treat that kind of angle closure when it comes with non-pupillary block mechanism? What's the cause of angle closure there when you give topiramate, or you said sulfa drugs sometimes?
The choroidal effusion.
Exactly. So it's caused by ciliachoroidal effusion. So what do you give?
Stoppage of the drug.
And most of the time, stoppage of the drug is sufficient. Any other thing you can do?
Then
No. Most of the time, it's stoppage of the drug. Something you see to see the fundus, no?
Dilate.
Exactly. You can put a mydriatic. You can put mydriatic cycloplegic in such patients. If your diagnosis is certain, bilateral, susceptible drug is there, anterior chamber is diffusely shallow, just like you treating a malignant glaucoma. So there you can put a mydriatic cycloplegic drug, which is exactly opposite of what you do in a pupillary block glaucoma. And
Can you tell me any neuroprotectives in the glaucoma?
Yes, go ahead, Rajni.
Immunoprotectives, neuroprotective agents in glaucoma, NMDA receptor antagonists like amantadine, and neuroprotective agents like beta-axolol, brimonidine, calcium channel blockers, flunarizine, nifedipine, and then nitric oxide synthase inhibitors like aminoguanide. Then
In your case, this patient is applying the drops.
yes,
What drops the patient is applying?
brimonidine is a neuroprotective drug.
Then
Beta-oxolol is a neuroprotective drug.
no, one more drug the patient is
Ripasudil
applying.
is a neuroprotective drug.
I forgot. Ripasudil, the patient is applying in right eye, no?
Yes, sir. Yes.
So this neuroprotectives are necessary for this case. For your case, because advanced glaucoma cupping.
Yes, ma'am.
Any other gene therapy?
Ma'am, hello, ma'am.
Gene therapy.
Gene therapy, stem cell transplantation, upcoming. Then I don't know, ma'am.
Dr. Lakshmi, just a moment. I am Dr. Bastin, Scientific Committee Chairman. If your presentation is over, you can just stop the sharing of the screen.
Okay.
So we can see each other and discuss. And please, all of you, switch on the video also. You can stop sharing the screen. Yeah. Yeah, correct. Yeah. Bye.
Any other PGs can ask any questions or anything regarding this case? If you have any doubt.
Dr. Ramalakshmi, good evening.
Good
Yeah,
evening,
sorry,
sir.
I couldn't start the session because I was traveling. And
Okay,
you can ask leading questions to the PGs who are joined in this session. So unless you ask, they won't open their mouths.
Okay. Nowadays, the surgical aspect, what are the non-filtering surgeries in the glaucoma? So the trabeculectomy is a external filtering surgery. So what is the non-filtering surgeries for the treatment of glaucoma?
Glaucoma,
Non-filtering surgery.
glaucoma draining devices, non-filtering surgeries, stent can be minimally invasive.
Okay. That is okay. You're right.
Minimally invasive surgeries,
glaucoma
eye
surgeries.
stent inject.
Canuloplasty. Have you heard?
Viscocanaloplasty. Viscocanalostomy. Laser sclerostomy.
Confusing, huh? Non-filtering surgery, sclerectomy, viscocanalostomy.
Yes.
Then this is a minimally invasive glaucoma surgery, canaloplasty, Schelm's canal. So you got to modify this structure, you are altering the structures. Then trabeculotomy. Then you told no eye stent, the micro device, they can alter the secretions that way. Okay. You told about the devices, the drainage devices. What devices?
Glaucoma drainage devices.
Yeah.
So 2-type valve devices and non-valve device. Non-valve devices are overlap non-valve glaucoma drainage devices, Barwards, then valve devices are
what is the express stent? Express stent. Nowadays, in the theory, there is so many questions about the minimally invasive glaucoma surgeries and glaucoma drainage device. It is also important for clinical aspect as well as for the theory. Okay, can you tell me the features of absolute glaucoma?
features of
absolute glaucoma.
Absolute glaucoma, there will be glaucomatous optic atrophy, there will be, and there is marked rise intraocular pressure. There is absolute scotoma can be the
Then what is the symptoms for the patient? The absolute glaucoma.
painful.
Yeah, it's very painful. Very painful. How will you manage this case? Absolute glaucoma.
Cyclodestructive procedures. If there is no visual potential, cyclodestructive procedures can be done.
What procedures? Cyclodestructive procedures.
Laser cyclodestructive laser procedures.
Photocoagulation.
Photocoagulation. Cryotherapy.
Define glaucoma.
Glaucoma is a chronic progressive optic neuropathy with associated optic disc changes and visual field defect. An important modifying risk factor is intraocular pressure.
This is a mechanism.
Mechanism of glaucoma. There are two theories: vascular theory and there is mechanical theory. Mechanical theory is based on if there is increased intraocular pressure, there will be axoplasmic compromise for in the lamina cribrosa, bowing of lamina cribrosa, and there is axoplasmic blockage of nerve conduction at the level of laminar cribrosa, and also at the level of laminar cribrosa there will be arterial ischemia is also contributed. Then in vascular theory there will be hypotension ocular hypoperfusion, which will decreases the blood supply to the optic nerve, and which will result in the apoptosis of retinal ganglion cells.
What is the primary angle closure suspect?
Primary angle closure suspect are the pupil, the patient which are there is iridotrabecular contact is more than 180 degree, but the IOP there with normal IOP, normal field defect, and there is normal disc.
What is the management for suspect?
Suspect if patient is asymptomatic, routine follow-up, but the other eye is patient with fellow eyes had an episode of acute angle closure or acute angle closure glaucoma. We can prophylactically give peripheral laser peripheral iridotomy to suspect patients.
Suspect, and also the periodic follow-up.
Periodic follow-up is
That is important. Will you confirm the suspect?
Confirmation of suspect, gonioscopic examination. Or other tests are ask the patient to sit in the dim illumination and check the variation of IOP if it is IOP.
Provocation test.
Glaucoma provocation test. If the IOP is more than 8 mmHg, there is a suspect.
Only darkroom provocation, any other?
Then mydriatic test can also.
Water drinking test.
Tropicamide eye drops put in the one eye and check the differences between the IOP level. If it is more than 8 mmHg, patient is more prone for angle closure.
Any other questions from anybody? That can be closed.
Just one more point, ma'am. Let me just mention plateau iris syndrome, plateau iris configuration, and then we'll slowly wind up.
Plateau iris configuration is the anatomical variation where the iris is ciliary body is anteriorly placed. Then it is one cause of primary angle closure glaucoma with the non-pupillary mechanism, and which can be treated by laser peripheral iridoplasty.
Yeah. So only when it's associated with glaucoma, you call it a syndrome. Otherwise, plateau iris configuration. Not cured by iridotomy. And unless you do an iridoplasty, you may have to indefinitely maintain these patients on pilocarpine or something to keep the pupil constricted. That is plateau iris configuration. I think that should be one point I would like to add. What ma'am asked you about absolute glaucoma. It's not possible to detail, to see fundus and all in the case of absolute glaucoma. So even externally, when you touch the eye will be stony hard, and there will be bullous keratopathy. Patient will be in severe pain. There can even be filamentary keratitis. I think that's
so many features are there.
Yes, that's what is expected when you are asked about absolute glaucoma. Right. I think anybody else who wants to ask questions can go ahead now.
Yeah, I think almost every aspect is covered. Thank you, Dr. Ramalakshmi.
Okay, thank you, sir.
Thank you very much for our invitation and join with us. And special thanks to Jasmine and Sheldon. Both of them are my colleagues at Manipal. And Hari, my junior at Manipal again. And nice to see you all. And Dr. Lakshmi Pradeep, you did a very good job and answered most of the questions. And I'm sure all the PGs who listen this session, I'm sure this will be a good rehearsal for your exam if you get such a case. So thank you once again on behalf of the scientific committee of KSOS. Express my gratitude to all of you who joined this program. Thank you. Thank you.
Thank you, sir. Thank you.
Thank you, sir.